Hi, my name is Matt Rettig. I'm a genitourinary medical oncologist. I work at the David Geffen School of Medicine at UCLA, also known as UCLA School of Medicine. So the question is, at what point in the disease spectrum do I see small cell prostate cancer, and how do I treat it? So first of all, prostate cancer, as we describe it in common parlance, refers to an adenocarcinoma, the gland-forming cells, which under the microscope look like cross-section tubes when they're more well-differentiated. This form of prostate cancer is what we speak about when we're talking about prostate cancer in general. That's the cancer that is responsive to hormone therapy, produces PSA. There's another histologic type of prostate cancer called small cell prostate cancer. And small cell prostate cancer is really a poorly differentiated neuroendocrine carcinoma, akin to small cell lung cancer. So small cell lung cancer, which is the most common site for small cell cancers to arise, is really a poorly differentiated neuroendocrine carcinoma. And it's important to note that it's poorly differentiated because there are well and moderately differentiated neuroendocrine endocrine carcinomas, such as an insulinoma or a glucagonoma, which can be well differentiated and not have the aggressive biology similar to that of small cell carcinoma of the prostate. So small cell carcinoma of the prostate is a very aggressive cancer. There's a very high proliferative rate, and when one stains the tumor for Ki-67, a proliferation marker, you see the majority of the epithelial cells staining for this marker. It also expresses neuroendocrine markers that are classically used for immunohistochemistry staining, or which can be used as a tumor marker. And these are tumor markers such as neuron-specific enolase, or NSE, and chromogranin A. And there are essentially two times when one sees small cell carcinoma of the prostate. The first, which is the rarer of the two, is at the time of diagnosis. So small cell prostate cancer is representative of about 1% of all newly diagnosed prostate cancers. So it's rare, it behaves very aggressively, and may be found concurrently with adenocarcinoma. If that happens, one should treat both the adenocarcinoma with hormone therapy, as well as small cell carcinoma with chemotherapy, as I'll describe in a moment. The other time that we see small cell carcinoma is in the context of prior treatment with hormone therapies. So small cell carcinomas are not driven by the androgen receptor. They may express the androgen receptor, but if they do, the androgen receptor is inactive. Consequently, hormone therapies do not have a role in the treatment of small cell carcinoma. When they arise in the context of hormone therapy, it's essentially an adaptation by the tumor to the hormone therapy. Essentially, the tumor says, okay, you're going to block my hormonal environment, then I'm going to morph or transform into a type of prostate cancer that is no longer dependent upon the androgen receptor. And that is small cell carcinoma. We also call it treatment emergent neuroendocrine carcinoma, or treatment emergent small cell carcinoma. This disease has a very aggressive biology. It's often associated with visceral organ involvement. So if I have a patient who is on hormone therapy, especially if they've received multiple lines of hormone therapy, for example, androgen deprivation therapy, and one or two of the novel androgen receptor signaling inhibitors such as abiraterone, prednisone, enzalutamide, apalutamide, darolutamide. These are the patients who are more apt to develop the treatment emergent small cell carcinoma. In one of the largest series to date, in patients who were treated with abiraterone and or enzalutamide with metastatic castration-resistant prostate cancer, about 15% of biopsies of metastasis had small cell carcinoma present. It could have been present by itself, or it could have been present in conjunction with the adenocarcinoma. And we actually know from genetic studies that the small cell carcinoma is derived from the same clone as the adenocarcinoma. So it truly is a transformation of the original cancer into a second cancer. They're genetically, lineagely related. So the small cell carcinoma patients actually have a similar PSA level as patients with adenocarcinoma. And that's because when they have small cell carcinoma, which doesn't produce PSA, they often have concurrent adenocarcinoma. So just because the PSA is still detectable doesn't mean the patient does not have small cell carcinoma. So it's important to consider an early metastatic biopsy in a patient who has a adenocarcinoma that is behaving aggressively, may have visceral organ involvement, because small cell carcinoma may be present, and that will require a different treatment and has a different prognosis. So the prognosis of treatment-emergent small cell carcinoma is very poor, associated with a rapid progression and short overall survival. And cisplatin-based chemotherapy is the foundation of treatment. The treatment is initially very effective. In other words, the vast majority of patients will respond to platinum-based chemotherapy. I often use platinum doublet. It could be cisplatin, it could be carboplatin, and it's used either with etoposide, or I like to actually add docetaxel, because docetaxel has activity not only for the small cell, but also for the adenocarcinoma. So a typical regimen that I might use is carboplatin at an area under the curve of 5 with docetaxel at a slightly reduced dosage as compared to the dose that would be used when docetaxel is used by itself. And that dose, when used with platinum, is 60 milligrams per meter squared as opposed to 75 milligrams per meter squared. It's also important to do a thorough somatic next generation sequencing analysis to try to identify potential mutations that we can leverage for therapy, although the utility of sequencing for patients with small cell carcinoma is certainly less well established than adenocarcinoma. I would also strongly consider trying to get patients onto clinical trials. There are a number of clinical trials that are in development and are active for treatment emergent small cell carcinoma of the prostate. I would encourage referral for clinical trials. Finally, I'd like to mention that patients who have adenocarcinoma with certain molecular features such as mutations in MYC, P53, on RB are at particularly high risk for transformation into treatment-emergent small cell carcinoma. So that's my approach and treatment of small cell carcinoma.